Yeah, today we will discuss about the inferior wall MI. Yeah, inferior wall MI and its variants of the inferior wall MI. Before that, I'll discuss about the coronary arteries. So if I zoom it here, this is the aorta. As you can see, from the base of the aorta there will be two coronary arteries arising. This is the right coronary artery which supplies the right side of the heart. To the left side of the heart you can see the left coronary artery. So this left coronary artery, again it will divide into left anterior descending artery and the circumflex artery. So this left anterior descending artery will be supplying most of the anterior part of the heart. That is why whenever you see an anterior wall MI, these patients will be having very poor prognosis, because this artery covers the large area of the heart muscle. So now we will discuss about the diagnostic criteria of inferior wall MI. Normally the right coronary artery will be supplying the right heart in 80% of patients, and the left circumflex artery around 18%. So it may be vice versa. So as you know, STEMI is ST elevation MI. So there will be ST elevation in 2, 3 and AVF leads, inferior leads. And apart from this, sometimes there will be T waves, which is called hyperacute T waves. And the important part in the inferior wall MI is there will be ST segment depression in AVL. This is very, very important, because any inferior wall MI ECG you take, this will be always be present. So this is considered as the sensitive marker for inferior wall MI. So this is the ECG. So there is an ST elevation in 2, 3 and AVF, and the reciprocal changes will be in the AVL, right? And now we move on to the other two variants. One is the inferior wall MI secondary to RCA occlusion, right coronary artery occlusion. So according to this, the diagnostic criteria will be the same: ST elevation in 2, 3 AVF, but the elevation in lead 3, ST elevation in lead 3 will be greater than lead 2, and there will be ST depression in lead 1. Apart from ST depression in AVL, there will be ST depression in lead 1. And when you take the right ventricular infarction, complete, there will be ST elevation in V1 and V4 right. So right side of the chest we put the V4. So the right ventricular infarction, there will be ST elevation in V1 and V4R. Yeah, and when you see the ECG, so what is the diagnostic criteria of inferior wall MI? 2, 3 AVF ST elevation. So in lead 2, lead 3 and AVF there is ST elevation MI STEMI, but you can see the ST elevation in lead 3 is higher and the in lead 2 it is little bit small, and there is reciprocal changes as usual, and there is ST depression in lead 1. Now we move on to inferior wall MI secondary to LCX occlusion. Right. So in LCS occlusion, same, there will be ST elevation in 2, 3 AVF, and here the ST elevation in lead 2 and lead 3 will be equal, and there will be ST segment depression in lead 1 apart from AVL. And in some ECGs there might be ST elevation in 1 AVL and V5 and V6, okay, and V5 and V6. So that can be called as inferior lateral inferior wall MI, where V5 and V6 1 AVL there will be ST segment elevation. And we move on to the ECG. As you can see, in lead 2 and lead 3 there is ST elevation which are almost in same height and AVL, right, and here you can see there is ST elevation in V5 and V6, so inferior lateral wall MI. And we move on to the other variant where there will be hyper acute T waves, inferior wall MI with hyperacute T waves. So as you can see, there is ST elevation MI, there are ST elevations, but there is the T wave is very large, right. There is one more ECG, one more variant of inferior wall MI, so which is called inferior wall MI with bradycardia, and in this bradycardia there will be heart block. Yeah, before that I'll explain the arterial supply of the right coronary artery. You see, the right coronary artery will be supplying the SA node which is present here, that is called SA nodal artery, and it will also supply the AV node. This dotted lines which you see, AV node, there is one branch of right coronary artery that is called AV nodal artery, SA nodal artery and AV nodal artery. So when the RCA is blocked, as usual, the AV node may go into ischemia, and because of this there will be heart block. And you can see the ECG here. Yeah, diagnostic criteria: ST elevation in 2, 3 AVF, AVL, ST segment depression, reciprocal changes. And if you see in lead 2, this is the complete heart block with inferior wall MI. As you can see, there is a P wave, QRS, and P wave again. There is no QRS again, P wave, QRS again, P, no QRS. There is no relation between P and QRS. So it is inferior wall MI with complete heart block. Complete heart block, CHB, right. And there is a interesting question, like the treatment of the inferior wall MI is always giving IV fluids. Why we have to give IV fluids in the inferior wall MI? See, with the help of this diagram, I will just tell you. See, normally the blood will be coming to the right atrium through inferior vena cava and superior vena cava into the right atrium, and then it goes into the right ventricle. From right ventricle it goes to pulmonary artery and then lungs. In the lungs it gets oxygen, and oxygen rich blood will be coming to the pulmonary vein into the left atrium and then left ventricle, and then supplies to various parts of the body. So what happens here is, now there is a infarction here. So now what happens, this wall, actually this right ventricle wall is thinner than the left ventricle, because left ventricle always supplies blood to the whole part of the body. That's why the wall of the left ventricle will be thick and the right ventricle wall will be thin. And because of this infarction, this right ventricle cannot contract adequately. So what happens, if this will not contract adequately, the less blood will be going to the lungs, and from the lungs the less blood will be coming to the left atrium, left ventricle, and the less blood will be supplied to the all parts of the body, and then there will be hypotension because of the less return of blood from the lungs to the left side of the heart. That's the reason what we have to do is, like, we have to increase the fluids, we have to give more fluids, so that if you fill the right ventricle even with less contraction, the excess fluid will be pushed into this and to the lungs, and the excess fluid comes to the left ventricle, so that the cardiac output will be maintained. So the only purpose why we are giving IV fluids in the inferior wall MI is to maintain cardiac output. So if you don't give fluids, what happens, this, because of the reflex, the left ventricle will be contracting rigorously, and the heart rate may go up to 160 or 170, and this persistent hypotension, patient may go into cardiac arrest. So it is very important, we have to remember this, giving IV fluids. And one more important thing which we have to remember is giving of nitroglycerin in inferior wall MI is contraindicated. Though some sources say it is relative contraindication, but it's better we don't give. So what is the action of NTG? It is a vasodilator. Vasodilator means it dilates the arteries and veins. Suppose if I give NTG here, as there is no pressure, if I give NTG, this will get dilated, the veins will get dilated, and still we are worsening the blood return to the right side of the heart. So further it worsens the hypotension. So NTG is absolutely contraindicated in inferior wall MI. Thank you.